Hello, everyone, and thank you for joining us for another installment of Learning with National Leaders. We welcome you to our virtual speaker series presented by Stilanovic Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis. I'm Carol Daniel, your host tonight. Our discussion will focus on something we can all do when it comes to preventing cancer. Get screened. We'll focus on other critical efforts we all can make when it comes to prevention, and we'll also discuss treatments. Joining us tonight are 4 Washington University experts at Stilanovic Cancer Center. Fun people as well. I just want to let you know that, okay? First of all, he is representing men tonight. Please welcome colorectal surgeon, Dr. Paul Weiss. Dr. Weiss, thank you so much.
Thanks, Carol. Appreciate it.
Great to have you here. Radiologist joining us as well, Dr. Debbie Bennett. Thank you. And lung screening supervisor and nurse, Ann Stilanovic. As well as geneticist, Dr. Patricia Dixon. Thank you so much. And thank you all for coming and for joining us tonight. A reminder to you, our viewers, submit your questions right here on this website. We're going to try to get those answers for you throughout the evening. We want to start tonight's conversation centered around breast cancer. So here's a did you know? About 1 in 8 U.S. women will develop invasive breast cancer over the course of her lifetime. In 2022, an estimated 280,850 new cases of invasive breast cancer are expected to be diagnosed in women in the U.S., along with 51,400 new cases of non-invasive breast cancer. In 2022, about 2,710 new cases of invasive breast cancer are expected to be diagnosed in men in the U.S. A man's lifetime risk of breast cancer is 1 in 833. So, Dr. Bennett, let's start with you. Women hear so much information about mammograms, breast cancer, and related topics, so we don't want any of you to tune out when we get to this. There's a lot of great information ahead. But if you forget anything else tonight, Dr. Bennett, what's the most important thing?
I think the most important thing for all of our viewers tonight is to remember that screening works. That's really the bottom line. So it's important to get screened. For breast cancer screening, that means starting at age 40 and getting screened every year. It really works to decrease your chances of dying from breast cancer over the course of your lifetime. You know, one of the themes of tonight is that everybody is important, that you are important, and I really can't stress that enough. I think for a lot of our women that are watching, there's so many things going on. We were just talking about this earlier tonight. You know, there's so many other people to take care of in your life. And the important thing to realize is that if you are not there to take care of them, then nothing else can happen. So take the 15 minutes that it takes to get a screening mammogram, go get it done, make sure that you get a clean bill of health so that you can be here for a very long time for everybody that loves you.
What are some of the excuses and I want to say excuses, let me change that because that sounds judgmental. But what are some of the reasons that we as women give to not getting a mammogram?
Oh, I mean, I can tell you because I've felt them myself. So I just turned 40 this year, and that's the age that we recommend that women start screening mammograms. My 40th birthday came and went, and I can tell you I still had not called to schedule my own screening. And I think it was for all of the reasons that so many people feel. First and foremost of which I think is a little bit of fear. I think there is this feeling like, oh my gosh, what if we actually find something? And I think that's a big part of why people put off doing it. It's not because they're scared about getting the mammogram or the colonoscopy or whatever the screening test is. It's because they're scared about what might be found. And so I will say, as somebody that does this every day, you want to, if something is there, you want to find it as early as possible. You want to find it as small as possible before it has spread anywhere else. The treatments these days for breast cancer are so good that as long as you can find it when it's early, you will have a very, very good outcome.
If there's something, screening will find it sooner, which means it's more treatable.
Absolutely, right. And I think the last thing that we want is for somebody to come in later who hasn't been screened, who now has felt something, and have them ask themselves, what if? What if I had come in sooner? Would the outcome have been different? And so we're here to tell you, do not worry by yourself at home. Come in, get screened, get all of the information, and we will take it from there.
Talk about screening guidelines, if you would. What should we be aware of?
Yep, the current guidelines are that every woman who's 40 and over should get a screening mammogram every year. There's a whole lot of people who actually should be screened earlier than 42. And so it's important to talk to your doctor by about age 30, somewhere between age 25 and 30, to find out whether you fall into that group of women that should be screened earlier. Sometimes that's because you have family members that have had a diagnosis of breast cancer. Sometimes it's because of things in your own personal history, and your doctor can go over that checklist and make sure that we're not missing something that would lead to you being screened earlier than 40.
You know, we talk about doing your own exam and feeling for possible lumps. And I'll be frank, we're adults here, but if you're married, if you're dating somebody and you're serious, my doctor said to me once, have your husband check. He's feeling you anyway, have him check. He may find something that you don't find, okay? But lumps are one thing. Let's talk about other symptoms we should be aware of.
Absolutely. So our recommendation is that each woman be familiar with what her breasts normally feel like. And any change that feels different to a woman should be discussed with her doctor. So you'd be surprised how many people come in and say to us, you know, something just does not feel right. And that's something that we take very, very seriously, is the intuition that something is not right, that something is going on. So whether that's because you feel like an area feels thicker than usual, feels like a lump, you're having discharge from your nipple that is not typical, or if you even have one area that hurts all the time, like in the exact same part of your breast, those are all reasons that you should talk to your doctor.
Thank you so much. Let's turn now to Dr. Dixon. As a genetic counselor, let's talk about the links that there might be between family. My mother had breast cancer. Sisters, aunts, we need to know about those things who have been diagnosed with breast cancer. How common is it, and what should we know?
Yeah, so breast cancer is very common, but hereditary breast cancer is not exceptionally common. However, if you do have a family history of breast cancer, ovarian cancer, or even any cancer pretty much where there's someone under the age of 50, multiple family members with cancer, if that is true for you, then you should talk to your doctor about getting a referral to see a medical geneticist like myself or a genetic counselor who we also work with, and potentially getting genetic testing for a variety of the genes that can predispose and increase your risk for cancer. Again, most people who have cancer do not have one of these genes, but if you do, it's important to know, because there are specific steps that you can take for your health as well as to help your loved ones and your family members take better care of themselves.
You know, we all agree that knowledge is power. And knowing your family history is a part of that knowledge and a part of the power. But getting family to talk about it might be a little more difficult. But knowing family history can help us, for sure.
Yeah, absolutely. And another thing that we see a lot is when there's a family history and a gene even found for, say, breast cancer or ovarian cancer, sometimes the men in the family don't want to go get tested for that gene because, I don't have any ovaries, you know, so I'm not going to get breast cancer. But the truth is that first of all, men can get breast cancer, and second of all, those genes that cause or predispose to a higher risk of ovarian and breast cancer can also cause other types of cancers that can affect men. So it's really important, men, that you also get tested for these genes if they run in your family, so that you can protect yourself and the women you care about.
As promised, we want to go to some of your questions tonight, and we do have one. First of all, it is about prostate cancer. Can prostate cancer diagnosed late in life impact the health of a daughter? Very interesting question.
Yeah, I can address that a little bit. So there's a higher risk of having a hereditary cancer when prostate cancer is metastatic, if it has certain kinds of features that your doctor would know about in terms of the pathology of it, if the person who has the cancer is of Ashkenazi Jewish descent, or if there are multiple other family members with cancer. Then if those are true, then I would talk to your doctor about getting referral to see a geneticist or a genetic counselor and maybe get some genetic testing.
Just a quick question about prostate cancer as well from another viewer. My father-in-law had prostate cancer in his 50s. At what age should my husband start getting his PSA level checked? And this is important for many reasons, but obviously a wife is monitoring her husband's health, and that is something that we all do.
Yeah, prostate cancer screening is now recommended generally for men 45 years and older, I believe. And then if you have a family history, it could be even younger than that.
All right, Dr. Bennett, let's go to another issue of the importance of mammography as an early detection tool. Let's talk about that.
Yeah, mammography right now is the best early detection tool that we have. And as we said earlier, the earlier and the smaller you can find a breast cancer, the easier it is to treat, the better the outcomes are. So it's very, very important to get screened.
And so there are studies, I understand, at Washington University and Siteman that suggest ways to do this. What can you tell us about those studies?
That's right. So there are some studies looking at ways to reduce your risk of developing breast cancer. So unfortunately, you know, the two major risk factors for developing breast cancer are being female and getting older. So those are two things that we cannot do anything about. But there are things that we can change. Your viewers probably are not going to want to hear this, but it's all of the same advice that we give for living a healthy lifestyle. So eating a healthy diet, eating your fruits and vegetables, getting enough exercise every week, making sure that you maintain a healthy weight. These are all of the things that we can do to reduce our risk.
And other types of screening guidelines for other cancers exist.
That's right. There are different screening guidelines for each form of cancer. I know Dr. Wise can talk about the colorectal screening guidelines. We've touched a little bit on prostate cancer screening. So it's very important to get your annual checkups with your primary care physicians. They can go through and make sure that you're up to date with all of the guidelines for screenings.
Dr. Wise, we're so glad you're here tonight. Colon cancer is the #2 cause of cancer deaths. And so we want to talk about colorectal cancer. What is it in the first place? Let's start there, shall we?
Yeah, sure. So obviously, whenever you hear about cancer involving an organ, so just like we're talking about breast cancer, it's basically an abnormal growth, a malignant growth that starts in the colon and can potentially spread elsewhere. I think one of the most interesting things about colorectal cancer, and we're going to talk about a number of different screening guidelines, those are all really focused on trying to identify a cancer early. And certainly with colorectal cancer screening, it's the same thing. But the nice thing about colorectal cancer, if there's anything nice about a cancer, is it usually develops with something that we call a precursor or a polyp. And so one of the cool things about screening is oftentimes you can actually identify that polyp and remove it before it ever has a chance to turn into a cancer. So it's one of the, I guess, neat things about colorectal cancer screening is we can actually prevent a cancer from ever happening.
Want to talk about colonoscopies in just a second. Don't go away. I know. So many jokes about colonoscopies, of course. I've had a few. But what are the screening guidelines for getting a colonoscopy?
Yeah, so if you're going to come away with one thing about colorectal cancer screening, it's that everyone should have screening by age 45. Now, that's a little bit different. I think a lot of us have that 50 age in our heads, but those guidelines were recently changed because we're unfortunately seeing colorectal cancer at younger and younger ages now. And so the screening has shifted to age 45. So if you come away from this talk with nothing, is that you should be getting screened by age 45. Now, just as we've talked about with breast cancer, we'll talk about with lung cancer, and as Dr. Dixon mentioned about the potential that there can be family or hereditary reasons, and there can be other conditions as well that put people at increased risk for developing colorectal cancer at a younger age. You'll find that speaking with your primary provider, your physician or physician extender who's helping to take care of you, they may actually recommend that you get screened at a younger age. So I think I saw a question that was coming through about, well, my siblings got colorectal cancer at age 30, when should I get screened? The recommendation is actually 10 years younger than that. So by age 20, you should be starting to get screened. And for people who are at high risk, you'll see a lot of these advertisements for all these different things that you can get done. Cologuard's the one we hear a lot about, but there's a lot of different other ways of getting screened. Those screening mechanisms are not recommended for folks who are at higher risk. So colonoscopy is the standard recommendation for those folks who are at higher risk for getting colorectal cancer. So if you've got a family history, if you have a known hereditary syndrome like Dr. Dixon can speak to that puts you at increased risk for developing colorectal cancer, if you've got other disease conditions that put you at increased risk, the recommendations under those circumstances are that those people get colonoscopies, not the other screenings, and start at a younger age.
And so it is funny when my brother just had I have 3 older brothers, one of them just had his colonoscopy, and we, on this group text, we're all shooting jokes at him.
Of course.
Of course, because that's what you do. There are so many misconceptions about colonoscopies, and it's not necessarily a pleasant. That thing you drink it doesn't really taste fantastic.
Nope, it doesn't. Drinking seawater is not pleasant. It doesn't matter how many flavorings you add to it, whatever else you have to do. It's a volume of fluid you got to drink, and it's pretty salty, so it's not pleasant. I have had 2, so I'm with you. I totally know how it is. I have a family history, so I had to go through that at a younger age, and so get it done. So I have experienced it. I have empathy and sympathy for everybody out there who's trying to avoid it. But I think, as Dr. Bennett mentioned, it's the same kind of thing. You're worried about what those results might be, and so totally understand not going through it. Wanting to avoid it is understandable, but it's incredibly important. And the prep is the worst part. Everyone worries about the thoughts about having a scope put in them, and that's totally understandable. But the reality is we give sedation medications to patients, and oftentimes now have anesthesia that's provided so that folks don't have to go through the tougher part of it, which is the uncomfortable part, to go through that. They don't have to go through that alone. But I do have a number of patients who have wanted to go through it without sedation, and while I personally wouldn't want to do that, and I tell them that, we have had some patients, and sometimes it's out of necessity. Maybe they don't have a ride or someone who can help them out under the circumstances, or maybe they have particular medical conditions that put them at increased risk. So there are circumstances where we'll do that, but the vast majority of people get sedation to get it done.
I've had 2 as well. And I said, give me all the sedation. If there's any in the back room, just left over.
It's one of the best naps you'll have.
It was the best sleep ever.
Yep.
It truly was.
Right.
And I woke up and I said, where's my husband? And I didn't even know. I didn't even know. It was like a whole morning. And I had 2 days off from work. So it was great. And it wasn't painful.
Right.
There was no pain. So we have to make that point, doctor.
Yes. It's not risk-free. There certainly is risks of having discomfort related to it or having other potential complications, but those risks are quite low. Some folks are a little bit higher risk, but in general, you're either the physician who's performing the procedure or your primary care provider can talk to you about those potential risks associated with it. But we should be clear, there are other screening modalities that are available out there. Colonoscopy is definitely the gold standard, but there are other ways to approach it as well. So it's talking with your primary provider as to what's the best screening modality for you is really important.
I do, in all seriousness, have a friend who lost his battle, did not get screened. He had symptoms we later learned and ignored them, and other cancer developed in his body. So tell us about the symptoms of colorectal cancer.
Yeah, so first, I'm so sorry to hear about that, because there's nothing more devastating to us as care providers to hear about folks who've gotten cancer and lost their battle with that, because we obviously are in this to help people out and save lives. And obviously, if we can prevent the cancer from happening in the first place, that's our goal. We would all be happy to, be out of a job and not have to be cancer providers to think that cancer's gone. But under the circumstances there, symptoms are certainly important, and unfortunately, a number of people will show up with symptoms. The main one that you hear about are changes in bowel habits, so unexpected changes. Let's say you've had a change in your diet, or you're taking new medications, and now you're having troubles with constipation or diarrhea. That may be related to that, but if you make adjustments back to your normal routine and that doesn't change, that may be there may be something going on, so you want to get that checked. Blood in the stool is certainly something we hear a lot about, and I've seen many, many patients, unfortunately, who've shown up, said, well, I thought I just had hemorrhoids, and I had blood in my stool, or I kept seeing blood, and it's just hemorrhoids. And we all know denial is not just a river in Egypt. Mm-hmm. It's something that we all have problems with, and Dr. Bennett mentioned that about getting breast cancer screening. We've all have those things of, like, it's hard to do it.
Human nature.
Yeah, and you think, oh, it's nothing, but boy, if it happens once when you're constipated and it's bright red blood on the toilet paper, like, okay, fine, that may be. But if it's something that's persistent, by all means, you should get it checked. And I would tell you, if you have any blood at all, get that checked out. Even if it's a small amount one time, just talk with your primary doctor and make sure they checked you out and it's nothing to worry about.
And Dr. Wise, you mentioned it. Let's go back to Dr. Dixon and talk about genetic factors here. What can you tell us about the link between family members who have been diagnosed with colorectal cancer?
So most of the genes, or the genes that cause a increased risk of cancer, tend to run in families in what we call an autosomal dominant fashion, which means that they're passed on with a 50-50 chance from parent to child. And so those genes give you an increased risk of cancer. They don't mean that you will have cancer for sure. So if you have a family history of cancer and it is in a relative where it's your parent or a sibling or an aunt or uncle, then you could potentially, and they have one of these genes that predisposes to cancer, you could potentially be at risk for developing the cancer. So that kind of is the link between family members. Again, most people who have cancer do not have one of these genes. Cancer is really common, unfortunately. But if you do have one of these genes, it can increase your risk pretty dramatically and can change the way that your doctor would manage your cancer.
And Dr. Weiss spoke of this, and I think it bears repeating that if there's a family history, does that change the frequency and the age of screening?
It absolutely does, and especially if you have one of these genes, it can change that dramatically, as well as changing surgical management or other management that the doctor would recommend.
So let's broaden that question a little bit. If you have a family history of any kind of cancer, as I mentioned, my mother had breast cancer. When is it time for someone to talk to someone like you and get genetic counseling?
I mean, the easiest rule of thumb is if you have a family history of multiple family members with cancer, or you have a family member with cancer who is under the age of 50 when they had the cancer, almost all of the cancers have enough of a risk of having a hereditary component that they would recommend that you talk to a genetic counselor.
Thank you so much. Let's move on to lung cancer, the leading cause of cancer deaths among men and women, making up almost 1 in every 4 cancer deaths in the U.S. Each year, more people die of lung cancer than from colon, breast, and prostate cancers combined. Overall, the chance that a man will develop lung cancer in his lifetime is about 1 in 15, and for a woman, that risk is about 1 in 17. Smoking is the leading cause of lung cancer, and quitting smoking is the best way to prevent the disease. That said, lung cancer also affects 10% to 20% of people who have never smoked or have smoked less than 100 cigarettes in their entire lifetime. So let's welcome in our lung expert now, Nurse Ann Stilanovic. Great strides have been made in the detection of lung cancer. Can you share who's at risk, first of all, of lung cancer? We've talked about those who smoke, for sure.
Sure. So as you mentioned, tobacco smoking is the single most important risk factor for developing lung cancer. Cigarettes, cigar use, and smoking pipes also contribute to lung cancer risk as well. And persons who smoke who have developed COPD, emphysema, pulmonary fibrosis, or have a prior history of lung cancer are at a greater risk of developing lung cancer than persons who smoke who haven't been diagnosed with any of those conditions. And other risk factors for lung cancer include having a family history, being exposed to secondhand smoke, having an HIV infection, and then also other environmental exposures, such as being exposed to asbestos or radon.
And for those who have not been screened, are there common symptoms that they should be aware of that we can give them tonight?
Absolutely. So common symptoms of lung cancer are a bloody cough, a new or a changing cough or mucus, weight loss, loss of appetite, fatigue, having a hoarse voice or noticing a change in your voice, and then also bronchitis or pneumonia that doesn't seem to be going away. If patients are having any of these symptoms, we highly recommend that they talk to their doctor as soon as possible.
And you said pneumonia that doesn't go away. What about reoccurrence of pneumonia? Some people get pneumonia again and again, it seems.
Absolutely. Yep, that would definitely be something to discuss with your physician.
I understand that the screening guidelines for lung cancer have been recently updated. Can you describe those for us?
Yes, so lung cancer screening is now recommended for people age 50 to 80. It is recommended for those that are smoking cigarettes currently, or they've quit cigarettes within the past 15 years. And then patients have to have at least a 20-pack year smoking history. So that equates to smoking about a pack of cigarettes per day for 20 years. And then it is also a requirement that someone who wants to get screened be willing to undergo diagnostic testing for lung cancer and potential lung cancer treatment if they were diagnosed. So we just recommend for people that meet all that criteria to follow up and have a conversation with their primary care physician or other healthcare provider to help determine if lung cancer screening would be right for them.
And do we have a sense now of just how much exposure to secondhand smoke is detrimental?
Unfortunately, I don't have any specific data on that. Again, we just encourage, someone if they have had a significant exposure to secondhand smoke, or certainly if they have other, family members that have been diagnosed with lung cancer, it would be an excellent conversation to have with your physician.
And we talked about breast cancer, and there's a doctor on the couch who has already turned 40 and needs to get her screening. We're not
I got it.
We're not going to embarrass anyone tonight. But with lung cancer screenings, why are people reluctant, who are smokers, in fact, who should get screened? Why are they reluctant? Is it the same issue, afraid of what might be found?
I do find that a lot, yes, when working with patients. I think sometimes with lung cancer, there's also a stigma of, I have been smoking for all these years. This is something, that I may have potentially done to myself. We really just encourage everyone, just to think about, though, lung cancer is really, as Dr. Bennett mentioned, most easily treated when it's detected at an early stage. There are a lot more treatment options available when it's caught early. By the time you start having those symptoms of bloody cough and weight loss and whatnot, many times the cancer has progressed to a later stage by that point and is much harder to treat and has a lot lower survival outcomes at that point.
You are worth the screening. You are worth the screening. You can get that done. We're going to ask a question about, we have a question about skin cancer coming up, but another question about secondhand smoke from someone who's watching tonight. Should a person who was around secondhand smoke as a child, and I'm one of those, be screened as an adult?
Excellent question. So unfortunately, as of right now, insurance is only covering screenings for adults age 50 to 80. That have that smoking history themselves. Hopefully that might change in the future, but as of right now, that's what insurance guidelines are covering. So again, a conversation that we recommend bringing up with your physician. Perhaps, the physician may be able to order a diagnostic CT scan or some kind of other test instead. If you feel very strongly about being screened.
And then this question about skin cancer. Our viewer says they tanned a lot in high school and they have a lot of freckles and moles. Should I start seeing a dermatologist regularly to monitor changes?
You want me to take that as the colorectal surgeon? I think that's the appropriate answer here. I would tell you, just from personal experience related to being a very fair-skinned person, that I would tell you, if you've got freckles and moles, why not? See a dermatologist. If your primary provider isn't comfortable with that, you might as well get get seen and get checked out, and then they will be the ones to kind of tell you whether or not you should get regular assessments. So that's my bias. Of course, I'm a colorectal surgeon. What do I know?
Anybody else want to add to that one? The answer is yes.
Yes.
The answer is yes. And they don't know this, but I was treated for skin cancer, and I thought it was a wart. First, I thought it was just a pimple, and then I thought it was a wart, and went to the doctor, and they've removed it, basal cell, so it's not the kind that would take my life, but still.
Yeah.
And as a black woman, that's something that we all should be concerned about. I wear sunscreen and always did, but now I think I wear 40, SPF 40 every day.
Yeah.
So.
Better safe than sorry.
Better safe than sorry, and I kind of like my skin, so that's what I'm going with. Thank you all so much. That wraps up tonight's discussion. I want to thank our panelists for taking time to join us this evening, Drs. Bennett, Dixon, and Wise, and Nurse Stilanovic. Thank you so much for taking your time and being with us this evening and for your wisdom and your advice. Now, make sure, my friends, to sign up for our next Siteman Learning with National Leaders discussion. You can start signing up for that event tomorrow by coming right back here to this site. Meanwhile, we invite you to visit GetScreenedNow.com. That's GetScreenedNow.com to learn about all cancer screenings that are available in your area. To learn about your risk of 12 cancers and other chronic diseases, and to get personalized tips for preventing them, go to yourdiseaserisk.com. That's yourdiseaserisk.com. We will see you back here next month as we discuss gynecological cancers. And as always, thank you for joining us. Take care of yourself.